We're going to talk about behavioral health and surgery for CMT. As Allison said, I'm at Cedars-Sinai in Los Angeles. I think most importantly for you all is I co-direct the CMT program. And we probably do more foot and ankle CMT surgery than anywhere else in the United States. So I've had a long experience and a lot of patience over the years. Is the sound on for this? I wasn't going to show this video, but then someone said to me, "Oh, you've got to show it." So some of you may have seen it, but if not, it typifies a bit why I'm here. We all know about miscommunication with people, the importance of communication. Maybe this actually could be your doctor and a CMT visit. But did you ever feel that way? I think a lot of people in this room probably have, because so many still feel that CMT is, the country music channel. I have no disclosures, I'm supposed to say that, but I should also say that my grandchildren are heavily involved with industry. Here you could see the H&F's logo on little Billy. I have no grandchildren, it's just a joke, but it's still good. We could turn the sound off, by the way, now. Thank you very much. All right. Hopefully, this will happen. There's a lot going on now, isn't there, with the drug trials. I think it'll hopefully improve CMT for so many. It's not likely to cure it all right away, but one day it will, right? One day I'm just not going to be needed anymore, just like as happened with polio and all the deformity from polio. I expect this will happen by Allison Moore, CMT cured. I'm not sure what date they'll be on it, but it will happen. But for now, there's so many people who can be helped with surgery. And surgeons like to operate and businessmen like to do business, and I'll leave it up to you to get a sense of where I sit on the surgery issue, because I tend to have a foot problem of my own. I got a terrible infection after my foot surgery 15 years ago, and I think it's given me a great humility about doing surgery on anyone. Okay. So let's go back 100 years or so, more than 100, to 1886. You've known this, you've heard this. Charcot and his student Marie, they described probably what was CMT. They had it wrong, though. They said it was coming from the spine. The fellow who had it right was Tooth, the Brit. My wife's from England, so I have to say that. But it's true. She wants me to say that. So let's fast forward about 100 years when I first went into practice, all right? And I came into my office in San Francisco, and there was a lovely young woman there, and I thought, what is this? A sports injury? Maybe she has some type of arthroscopy that she needs, or a ligament tightening of her ankle. And we were in a room with no windows, and with fear, really, trepidation in her eyes. She said, "I'm going to show you something no one has ever seen before." And she took off her shoes, and there were these gnarled feet. She was slender, very lovely. And, we lived in Northern California. They were like the live oaks that you have up there, these gnarled feet. And I looked at them a little surprised, or very surprised, and she said, "I have CMT. Do you know what that is?" And perhaps it's the greatest white lie I've ever told, but I looked her right in the eye and I said, "Of course." And she said, "Well, thank God, so many people don't know what it is." But I made up for that white lie, because after operating on her, she started to go out on dates. She got married. She has children. She hikes through Yosemite. We've kept up. And I spent the next 30 years learning what CMT is all about, and I think making some good advances in this field. Let's see there. So there's a wide spectrum of disease. We've seen that today, yesterday especially. And in the most advanced cases, the hands become involved and breathing becomes involved, and that could be so difficult to have any type of normalcy in your life. But in my world, the foot and ankle world, I'm an orthopedic foot and ankle surgeon. What we see is a fairly consistent presentation with two types of feet. So, you know, for the sake of this talk, we're really lumping, right? But there still are. There's someone like this 16-year-old woman from Texas. She really has no function. She's basically paralyzed below the knee. Now, she's pretty good at walking, but she's young and she can balance, but she doesn't have anything there other than her balance ability. In these patients, and I just want to touch on this now because we're not going to discuss it for the rest of the talk, braces are a godsend, all right? For people who have no real function below the knee, get a brace. There are hundreds of different ones. You have your favorite. You've got your favorite. Allison's got her favorite. Some cost this. Some cost 10,000 this. But get a brace. Don't let anybody, in my opinion, fuse your ankle. I still see people who have no function below the knee. They've come in with an ankle fusion. And all the wonderful benefits of these braces called ground reaction force braces are negated. And they have a very stiff gait. So basically paralyzed below the knee, no surgery if the foot's flaccid and flat on the ground, flat. This type of woman, this young woman, she has really no function again below the knee. Oh, she's doing pretty well holding onto the wall, but look in a brace how she is, how fluid. If she'd had any surgery, all we could have done was made this impossible. All right. So this is what I'm talking about. This is my world. Some of you have this, some of you have it mildly. This is cavovarus foot, an extremely high arched foot. This probably is about 80% of CMT feet to one degree or another, associated with some loss of feeling, some lack of proprioception. Sarah is 16, and she comes in and she said, all I want to be able to do is walk down the high school aisle without holding on to my dad. That's all I want in my life. And she couldn't do that because of this foot. This gal, she's from Australia. She said, is there anything that I can do for my foot? She sent me this video. Because both of these people were put in braces. Both of these people were actually tortured in their lives. Life's hard enough for them, right? And then to give them a brace that tried to fit that foot in is really unconscionable. And I think if there's any reason, other than my mom lives in New York and it's nice to be able to go see her on this trip, if there's any reason that I came, it's because of this message. This foot should not go into a brace. It should, and yet it happens all the time, constantly. You know people, you know friends who have this, and it's wrong. I see this once a week in my office. I'm so depressed, Dr. Pfeffer. I have no behavioral health. And it's no wonder. Go home if you want to explain it to your kids and get a puzzle with a round hole and give them a square peg and say, put it in. Even this type of foot, which is certainly mild CMT, is not going to do better with a brace. Even this type of foot, where this young man said, I want to do sports. He's not so bad. He's not so bad. But he said, I fall over in sports. I can't keep up with my friends. That's just not a balanced foot, is it? It's just not flat on the ground. So if you want to remember one thing from this talk, please remember flat on the ground. If you want your friends to understand what's going on with CMT, I think that's a mild foot. And those feet that are much more rigid, especially ones in a brace that doesn't fit, is more like this. Try it at home. For someone who doesn't have CMT, and they'll know what it feels like to take every single step of the day with those types of feet. So what causes the cavus feet? Well, it's muscle imbalance. And this is simple. I used to go into this issue more in the talks, and then I realized it's really not important. What happens with the disease is certain muscles in the leg are affected, and others aren't. So just like this arm wrestle, the outcome's inevitable. And as you have certain muscles pulling hard and other muscles pulling not as hard, you start to get a twisted foot. And if you start to develop it when you're 5 and you're still growing and your bones are forming, the bones actually start to twist. With the imbalance of the muscles, the toes start to deform upward. This is because the small muscles in the foot start to give out. Not so bad, but it certainly prevents a 20-year-old young woman from putting a cute shoe on that she could wear for a Federal Express or UPS job. Right? She can't do that. But those are real stories. I'm not picking on Federal Express or UPS, but those were patients who came to me and said, I can't wear a shoe that's acceptable. As the muscles weaken further in the leg, these toe muscles start to try to lift up the whole foot. Many of you know this. When you get a foot drop and the toes deform further, and then the foot becomes unbalanced. You can't fit it into a shoe. Often, usually, you can't fit it into a brace. It's not flat on the ground. That's all I want you to remember. There are a lot of great messages from this morning's talk. That's my message. You need a foot that's flat on the ground. Paralyzed and flat on the ground is fine. Rigid and flat on the ground is fine. Just not crooked in a brace or crooked without a brace. That doesn't work for anybody. Here's a CAT scan, a 3D CAT scan that we actually used for research that shows the incredibly high arch and the toes that are upward in this woman with CMT. You can see the calluses that she develops on the side of her foot and the fracture that occurred beneath the callus. Even a steel girder will rupture and fracture if it's placed under enough stress. And that's what happened to this bone. Cracked. That left foot. Who could live with it? Why does CMT cause pain, we ask? Have your buddy try to walk on the side of their foot, maybe just a couple of miles on concrete, and ask them if it hurts. That's what it's like, right? We all know that. There's no shock absorption in these rigid feet. Now, as it progresses in the foot, all of the muscles can start to get paralyzed, but if the deformity is present, you don't have a foot that's flat. We start to get a drop foot. We all know about that. The ankle becomes loose, and every step is just teetering over. And as I said, people come to the office and they said, I'm walking like this on the sides of my feet, but I'm told the pain is from neuropathy. Yeah, I'm sure the pain is somewhat from neuropathy, but certainly not most of it. So what do you do, right? How do you know? I just saw a 22-year-old who I operated on. She's had 5 failed surgeries. The family came from, I forget, the East Coast. And she said they've never found a doctor who would look them in the eye and said, the 6th surgery will help. Well, the 6th surgery will help her. But they were so lost, and they were so disillusioned, and so depressed, right? Have one marriage work out? Well, all right. But the 2nd, and the 3rd, and the 4th, and the 5th, my ex-orthopedic partner, he said, I'm getting married. I said, Lionel, he's now dead. I said, you've been married 3 times before. Maybe it's not a good idea. I don't mean to laugh. It's really tragic, actually, right? He got married again. Why does this happen? Why do people not end up in the right place? Well, there's a lot of disparity in the country about CMT surgery, and the brace makers make braces. I tallied it up last night about 2 in the morning when I couldn't sleep. I've referred 100 people for braces for every one the brace people have sent back to me. That's a lot of people over 30 years. Why is that? So what are the primary goals of surgery? The goal is to preserve motion. Yeah, sometimes you have to do a limited fusion. I haven't done a triple arthrodesis in 20 years on a young person that still has some flexibility in their foot. You want to get a foot that's what we call plantar grade or flat. Balance those muscles that are pulling, right? You can't get anything to work with that one big arm on this side and a little guy on the other. And then even if you can't walk afterward, even if, God forbid, you still have paralysis that doesn't let you walk, or God forbid the disease progresses and you get paralysis that doesn't let this foot move, you still are easily braceable. As opposed to wearing a bigger brace, you can get a very simple brace, maybe just for that dropped foot. So this is what we see. This isn't a bad example, but even remember that video before of the more mild examples. This is what both feet looked like on the left. That's what the right foot looked like after surgery. This is all completely obtainable. There's what the foot looked like on the right, on the pre-op, and that's what the foot looked like on the left after we'd operated on the person.
Is that all toe fusion then?
None of the toes are fused. They've just been straightened out. They've been midfoot osteotomies, tendon transfers. That operation will take me about 3.5 hours. I'm not that quick. I'm a moderate speed surgeon, but 3.5, 4 hours. We just did two CMT patients on Wednesday. That was a long day, you know. We didn't get out till probably about 5 o'clock at night. There it is, the one on the left. The slide left has been operated on. It used to look like the one on the right. We use nerve blocks. We're studying this now. There's one study in the literature about nerve blocks in CMT patients. It can be done. If you have good people, it can be done. You don't have to worry unnecessarily about getting worse after a nerve block. And that's cool because all the surgery is done as an outpatient. You go home. I want you home in your bed with your medications, not in the hospital with the nurse, no matter how good the hospital, how good Cedars is, with a nurse modulating your pain medicine and, you know, in somebody else's bed. So you'll have no pain, hopefully, for 2 or 3 days. We do it under loop magnification. I was trained as a hand surgeon. And this is briefly, you know, the types of things we're doing. We're moving these tendons. These are the tendons on the lateral side, the outside of the ankle. We're transferring the strong ones that are are the deforming force to the weak ones. We're cutting wedges of the bone out of the heel. It's very orthopedic. I'll look at some 16-year-old young person, you know, I'll say, this is what we do. You know, it reminds me of that Winnie the Pooh. He said, this is what Tiggers do, like when he stole the honey. This is it. This is what I do every day. We put in screws, we cut bone. It's creepy, I tell people, but it's what we do, and it works. That's the bone wedges being taken out. We rotate the heel. In more severe cases, we have to take these types of wedges out of the bone. The key is to get it all done the first time and get it done right. I'm sure some of you had this surgery. I'm not the only person in the country who can do it. Now, anyone who doesn't want to see some blood and operative pictures, close your eyes. I'll let you know when you can open them. Or the person next to you will let you know when you can open them. But I'm going to show you some operative pictures just about what we do. There's the heel. It's been cut. And I can put that heel anywhere you want. Some of you statistically have probably had surgery and your heel is not where it should be. It's still interned. The best of surgeons in this country will tell you, I have a hard time getting that heel where I want it in a flat position. We cut bone, we put in screws, we transfer tendons. Who would want to have it, right? Yeah, Bernadette. Who would want it unless it means that you don't need to wear a brace or that the brace you need is not as formidable? You can open your eyes now. All right. We're almost done. Again, with surgery, the toes can get straightened out. Right side had been operated on. And these people couldn't move their ankle up. They had crooked feet like the ones I showed you. It's wonderful, just wonderful. That's not for everyone. Someone has to be a very good patient to go through this. I saw a young man who's really quite impaired by his problem. He's near a wheelchair, and he said to me, I'm fine, doc. I'm 17 years old, and I'm just fine. And then his mother brought me aside, because they obviously had a disagreement, and she said, Dr. Pfeffer, he does nothing, nothing. He sits at home, he watches TV, he hangs out with the wrong kids. So that boy has to come to the conclusion, though, that he's not fine. Because, you know, kids at 17, things are fine, and they're doing well off it in their mind. It's interesting, I operate on one foot. There's maybe great trepidation, especially in a young person, but even an older person. And they're at surgery, I open up the dressing, and they look at their foot. This just recently happened. This young woman, she's 16, and she turns to her mother, and she said, Mommy, I want to do the other foot too. Right? There's no uniform surgical approach, which is fantastically frustrating. On Sunday, I'm holding a consortium, a think tank in Chicago. I've invited the best and brightest minds in the country, in Canada, to come to try to discuss this issue, to come up with guidelines for the foot and ankle. Yesterday, I announced that with the help of an H&F and their grant for $25,000, we're starting also the largest prospective multi-center study on the outcomes of CMT surgery. I think I'm right, but a lot of people think they're right. But this will help us understand that. Surgeons tend to have very strong opinions about what they do. This was one of my colleagues talking at a meeting recently. I disagreed with him, but this could be the Kavanaugh hearing. That's a joke, but I see people probably once every couple of weeks with failed CMT surgery, done elsewhere. In this particular case, the surgeon just hadn't addressed that very strong posterior tibial tendon. And to be 22 and to go through 6-7 months of recovery and have it recur, how horribly depressing. Not all my surgeries, I'm sure, are perfect, but I haven't heard from anyone yet that's not doing well. Let's put it that way. Patients come in, they go, God, Dr. Pfeffer, there's a blog, they're discussing you. People talk about you. I said, who's not doing well? I'm sure they're not all perfect, but if you do it right, it's very gratifying. Now, we recently came out with a paper on this. This was on 3D prints, on how to do these surgeries. I can't do a scientific study on 20 of you. The way we would do a scientific study is we would take one of you as a bad foot, we would duplicate you 20 times, right? 10 of you I'd operate on one way, 10 of you I'd operate on another way, and we'd see who does better. That's a scientific study, but we couldn't do that. So what we did is we took a model of a foot. That's a 3D print. That's a print that you could hold in your hand of this person's deformed CMT foot. And with very specialized jigs, we did 18 different types of cuts in the bone to try to understand which would work best, right? We actually came out with that paper, and it won a national award at the American Academy of Orthopedic Surgeons as a study most likely to change orthopedic care in the next 3 years. We just got that last year. This was the young woman, in conclusion, whose foot we modeled that CAT scan on. I told you about her. That was Sarah. And all she wanted was to walk down the high school aisle. Nothing more, just so she didn't have to hold on to her dad. And so we operated on both feet. Here she was after the second operation. And here she was at the party she had for graduation. I called her recently. There was a newspaper that wanted to do an article on CMT. It never happened, but I tracked her down through her mom. She's in college. She's 22. I said, how are you doing? Always timid that she's going to say, oh, not very well, Dr. Pfeffer. And she said, I'm great. I said, well, really? Really? Tell me. She says, I'm waiting tables at a pizzeria 4 hours a night. I just went to London and walked around town in cute shoes, and I'm going off to law school. Every week, we see these families. Evan from Chicago, Israel, Russia, Libby from Texas, Mr. Daniels from Boston, Colorado. And it's just wonderful because they take the dressing off, and even though it's bloody, and even though they're scared, and even though there are 40 sutures that have to take out, they look down, the family knows, and they know that they're going to have a good foot. This person could never lift up their ankle, and they had one of those crooked feet, and they were all the dressings we just took down. Thank you. It's interesting that, I think you'll understand this, but in the past 3 or 4 years for me, I've gotten more from these patients, I think, than they've gotten from me. Or at least it's equal. At first I thought, well, I'm helping everybody, gosh, I'm doing my job. But recently, many of us know this from some experiences we've had, but my life is so much richer, so much more spiritual, if you will, for doing this work. So someone said to me, "You going to retire soon?" I said, the only reason I'm not going to retire ever is because of CMT patients. So thank you all. All right, we have time. Sorry to be corny about it, but we have time for, I've got this plane, but I got 5 minutes for questions if there are any. Yes, please. Please.
So the first one, thank you. So my first question is, do all patients qualify for this or CMT, or what would not?
Well, it's a good question, and I didn't really dwell on that here. It was more surgical, but so the patients who have no motor function, right? Allison's here. I don't think she'd mind. Allison is like this. She really doesn't have anything motor-wise going on below the knee other than her Achilles, right? She's the perfect person for a brace, what's called a ground reaction force brace, which she wears, and you see how she skirts around the world on your behalf. So those people I would not operate on.
Okay.
Anyone who feels unbalanced with their walking, anyone who feels like they're falling over, the heels are in, the foot is rigid, let alone someone who's not braceable, because their foot's not flat, should have surgery.
Okay.
If they have, and, the longer you wait, the harder it is.
Okay.
So to operate on the 80-year-old is trickier. I just operated on a 12-year-old, and honestly, they had waited a little too long because everything gets so tight and so contracted. Does that make sense?
Yes. The next question is, do you do both feet at the same
No.
time? No.
It's
I
impossible.
didn't think so. Okay.
It's just impossible. It's too much for everybody.
And once they get surgery, are they still braced afterward, or is that like you would
Depends on the
determine?
foot.
Okay.
So someone who's paralyzed below the knee, but they've let it go so long, or they brace people, or whoever has told them to let it go, there's nothing you can do, or they've been scared of surgery, or they didn't know there was surgery, right? And they come in with feet that are like this and not flat on the ground. We can make them flat, but then they'll have to be in a brace.
Okay.
But often it's just a brace for a foot drop.
Right.
You guys know those kind of simple
Right.
braces.
And the last question is, do you recommend for these to be done at the CMT Center for Excellence, the doctors that we see there?
Sure, yes. But yeah, tricky question.
Sorry,
Of course.
I didn't mean it to be tricky.
I do. No, I do. It's just different, and the problem is you don't know until it's too late. Like, I've never been able to invest my pension fund with anybody, ever. So all I do is lose money, because I've never found anyone I could really trust enough. And I think it's sort of the same here. So I've ended up hurting myself by not doing it. You need to find a surgeon who you trust, but you need to find out how much they do. When I was trying, I was really humbled, because I went up to invite people to our think tank on Sunday, and these are the world leaders in foot and ankle, intergalactically famous people in your towns. And I would say, as I was recruiting people, I really want you to come, Anna, but can I just ask, how many surgeries do you do a year? And people would say, oh, we're busy. We do 1 or 2 surgeries. Or we're really busy. We do 5. I mean, last year we operated on 25 or 30 people. There are other people in the country like me. The problem is I just don't know who they are yet. Okay. So during the summers, for example, this past summer we must have had 10 families fly into LA, the commitment of parents and families and wives and husbands, and they stay there. And they had 1 foot done, and then they had the other foot done. They're coming from Boston and Canada and overseas. I don't yet know who to tell people to go to who have as big experience as we have. So that's you need to ask the surgeon there and say, how many of these surgeries are you doing a year? Are you doing 15 or 20 or 25? It's hard to know that number, though.
Okay.
Does that make sense?
Yes. Yes.
So, of course, the Center of Excellence is the place to start, but then you need to really know what's going on with the surgeon. All right. Okay, ready? Yes, please. Here. In front. Yeah, I'm sorry.
I have a couple of questions. So one is, how do you know if a triple, I don't know the medical terminology.
Arthrodesis.
Yes, was successful or not?
Well, a triple arthrodesis is done only for 2 reasons. One is because there's arthritis in the foot of an older person or a younger person where the joints are no good and worn down. That white covering like that you see on the end of a chicken bone, or Thanksgiving time, that white cartilage is just worn down in the joint. That's arthritis. For that, you would fuse bones or joints in the back of the foot, or because of a foot that's very deformed. But as I said, I rarely do a triple arthrodesis. It was a very, very common operation in my training. It takes away, remember that slide of the car going along with no shocks? It really takes away all of the shocks in the back of the foot. It's not a bad operation, not a bad operation at all if it's done well. So you'd know it's successful because the foot's completely flat on the ground and the person has no pain in the back of their foot. They have a stable construct, right? The problem with the triple arthrodesis is it's completely unforgiving. If you're a little bit tipped, that's how you're going to walk on it, a little bit tipped. You know. But what I'll do, as opposed to triple means three joints. What I'll tend to do, and I don't do this infrequently, probably in about 10% of patients, I'll just fuse one of the joints, the subtalar joint. You know, when someone has a lot of paralysis in the back of their foot, but not so much that they are only a candidate for a brace, often you'll have to just fuse one joint. But in general, look for a flat foot, look for a painless foot, look to not have a fusion if you don't have arthritis in the foot, and make sure that when you leave that operation, it's just perfectly flat. And don't be demoralized by this. The problem with patients with CMT, and I say this from the only perspective I can have, which is my perspective. You see, I have no motion in my left foot, side to side. And I was screamed at soccer at 15, and I couldn't run around the track in one direction when I could the other. So in my own way, I get it a little bit, you know. I could only ski to my right. I couldn't really turn to my left, especially when I was tired. And I saw 10 doctors in New York, 8. My dad was a professor of surgery. He took me to the best. They all thought I was crazy. Orthotic after orthotic. And I didn't know what I had, just to show you how difficult it is to have any self-insight, right? Until I was 40 years old. I just woke up one day and said, this is ridiculous. And I got an even better MRI of my foot than I had before, and it came back normal. And I called up David Stoller in San Francisco, who's a world-famous radiologist. I said, David, my MRI can't be normal. But because I sent him hundreds of MRIs a year, he said, it is. But because I sent him hundreds of MRIs for business, I got a call back. Maybe about 15 minutes later. You know, he looked at it again. That wouldn't have happened. He said, oh, by the way, Glenn, do you know you have a big congenital spur in the back of your foot that doesn't allow you to move? I almost fainted. Literally, I almost fainted. So that's the difference between in your family, everyone knows they have CMT. You tell your 5-year-old, you may have this, right? Versus the family where someone at 22, 23, 25 finally figures out they have CMT, right? You understand this all better than I do.
And
I'm not sure I answered your question. I kind of veered off.
You did.
Okay.
That way I just know if the surgery was successful or not.
Yeah, sorry.
And then the second question I have is, if someone has had hammer toes for so long where the bones are permanently contracted and fused, what do you do?
That can be fixed.
How is it fixed, I guess?
Yeah,
We
used to see that very commonly in patients with inflammatory arthropathy or rheumatoid arthritis, very worse than people with CMT. So what you end up doing is you'd end up taking some bone out of the small joints of the foot to straighten it up, and then you would actually, in the worst case scenarios, end up taking bone out of the joints, the knuckles of the foot. And you'd almost guaranteed of getting a straight foot.
What's the recovery time on that?
6 weeks. What else? Please. I don't have any special technique. I really don't. That heel technique we have is novel, but that's now being published, and people are understanding that technique better. If you asked every orthopedic surgeon who's a foot and ankle specialist in the United States how to operate on a CMT foot, every single one would know. For the very typical CMT foot, of which there are not many. One of your daughters is similar to the other. You know, they're all yours, but they're very different. And that's what I found with CMT, that routine cookbook, if you were, response to the CMT foot leaves a lot of people with inadequate correction. Does that make sense? But there's nothing special I do. Every foot and ankle people do this. There's I've just been very interested in this. Many of my colleagues have been interested in total ankles, and many have been interested in bunions. But I've been very interested in CMT, and through the HNF and the CMTA and other organizations and word of mouth, we get so many people coming. You get good at it. I feel like you just trained for decades and you get very good. So there's subtleties in CMT foot that need to be addressed to have a perfect result. But we'll know much more in the future. In the years to come, we'll really know who's got this down in the country and who doesn't. At the moment, I can't honestly tell you. Yes, please. And I'm going to have to leave in about 4 or 5 minutes. So
prior to our diagnosis.
Oh, here's the microphone.
Start your question over, please.
Prior to my son's diagnosis, he had a high arched foot with a hammer toe, the big toe, and drop feet. And I know you and I had a conversation a couple of years ago, but I'll just refresh. So he ended up, through the orthopedic surgeon, suggested doing tendon transfers to help with the lift. So he did bilateral tendon transfers at the same time. Very brave.
It's a lot of surgery.
And within 5 weeks after the cast come off, he went from a high arched foot to like flippers. So he was now walking on a drop foot that were flopping. So he had to go back in for surgery and get fused. I think it was just maybe the one joint. So he's now 20 years old. This happened at 12 and 13. So now as I look at his feet, I see where his toes are kind of moving out, either the left or the right. You can see where a bunion's starting to form. Now, mind you, that big toe is fused. So I'm a little concerned at the age of 20 since he's gone through that. And again, it was prior to a CMT diagnosis.
Yeah, that's hard to understand. And I've seen some overcorrections from CMT, which is what you're talking about, but it's rarer than hen's teeth. I saw that problem once, and I spoke to 10 people around the world, and they said, gee, we'd really never seen an overcorrection. But, I left cards here. So again, just send me his email. I just like seeing all this, and I'm glad to help. Just send me some x-rays. Anyone has it? Glenn, what's your opinion? Anyway, what else? Do we have another? But sorry to hear that.
We have one last one over
One
here.
last. Yes, ma'am.
Very quickly, on the other side of the coin, are there any medical treatments going on? Any drug therapies? Any clinical trials?
Well, there are a lot of drug therapies and clinical trials. I don't know if you were here yesterday, but that's what but that's not really my bailiwick. But for sure, the drug trials today are not going to give you a pill and cure your CMT. So at least for a decade, I know, find me. This will come. It's just really beginning now with a lot of these drugs. But if you look at the trials, it's they're incremental changes. They're not going to be curative overnight. But we're certainly on the right track with that. That's why I said with my slide, one day I'm not going to be needed for CMT surgery anymore because there won't be any deformity. But that's going to probably be still for a little while. Thank you.